Welcome back to NBME 26, only the most high yield topics, everything you need to know by the time you finish this exam. These are my questions. Here we go. So we got to give somebody atovaquone and azithromycin. Why? Because they're a 68-year-old man with splenectomy, high fever, dark urine. After they went to Connecticut, they have elevated LDH and low hemoglobin. So this is going to be babes. So babesia, atovaquone, and azithromycin is first-line therapy, especially in immunocompromised peeps. Tetrad, hemolysis in a patient with tick exposure and asplenia is going to tell you it's the dead giveaway. Chloroquine, let's talk about chloroquine here. That's effective with malaria. All right, so that's going to be like for plasmodium, not for babesia. And I think we had a negative PCR test on that. Definitely not malaria in this case. Penicillin G. So the buzzword there is going to be gram-positive bacteria or syphilis. So this is going to be irrelevant for a protozoal infection. So penicillin is not going to help with that. This is a protozoal infection. Doxy alone. Well, so Lyme or rickettsial diseases, you think of doxy, but it's useful in Borrelia and Anaplasma, but not in babesia. So it's malaria mimicking. It causes fever. It can also cause some fatigue and hemolytic anemia, but unlike Plasmodium, the smear may show this Maltese cross thing, and the PCR for malaria is going to be negative. Negative PCR for malaria, and the Maltese cross is going to be the giveaway here. And the spleen usually clears these infected red blood cells, so without it, the parasites are going to multiply. So if you have asplenia, definitely watch out. So atovaquone plus azithromycin is going to be your treatment for babes. Babe. Think of like Will Arnett in that one scene from Hot Rod. Sodius tick also transmits your Borrelia. Asplenia, you can't clear. Hemolytic anemia is what causes the increased LDH and low hemoglobin. Babes, Lyme disease in the endemic areas. Rings, Maltese cross. Okay, so the pathophys is tick bites you, chomp, enters the blood, reproduces asexually, rings form, red blood cells rupture, more parasites. Asplenia, it's really bad. Now, sometimes it's easy to confuse Borrelia and babes. So Borrelia, Sodius tick, it's co-infection with the same tick. Whitefoot mouse and deer, HLA, autoimmune, so chronic arthritis. Babes is going to be asplenia associated, so northeast, same as Lyme disease. Immune compromised hosts are at high risk. The pathophys, so we have a tick bite. So the babes enters the RBC, replicates their hemolysis, anemia, jaundice. Borrelia spreads hematogenously, triggers inflammatory problems. And so the target tissues are skin, joints, and heart for Borrelia. Babes, in asplenic patients, you have the lack of splenic problems. Asplenia, babes, my spleen is killing me. Borrelia, skin, joint, heart. Here's a practice question just in distinguishing them. 65-year dude, fatigue, fever, dark urine, one camping, Massachusetts, and T1 out of splenectomy. So that should just make you think more of babes automatically on this test. Maltese cross hemolytic anemia points it further away from Lyme disease. So why not travel abroad? Why not Borrelia? Same region, but there's no rash or arthritis. Lyme does not infect the red blood cells. Red blood cells is going to be the babes. Anaplasma, granulocytes. Okay, yeah, so that's how you distinguish them. Just important to know, a single tick can deliver not one, but two different parasites, babes and Borrelia. They both ride on the Ixodes tick, hitching a ride. So Borrelia can cause Lyme disease. And it's got its bullseye rash with late onset arthritis. Babesia sneaks into the red blood cells. And it mimics malaria with its fever, hemolytic anemia, and a smear that shows the Maltese cross tetrads. Okay, babes, what happened to your spleen? Okay, we're gonna go on to the next question, the next topic we need to master for this test. 36, Crohn's disease, started on infliximab. 2 months later, weight loss, all this stuff. X-ray shows upper lobe cavitary KT. What plays the most important role? It's gonna be IL-12. Why? Because it's secreted by macrophages. After TB activates so IL-12 activates the Th1 differentiation that leads to the interferon gamma release from macrophage. And the macrophage activation. Macrophages are going to organize into granulomas. And so now you get a granuloma formation, histiocyte stuff, and blocks off and walls off that infection. That's how you get the caseating stuff. So IL-12, Th1, interferon gamma, and activation of their macrophages forming these walls and granulomas, hence the TB. That's the big idea. So that's how tuberculosis works. That's how the wall forms, right? IL-12, interferon gamma. Macrophages affected with the TB wall of IL-12 recruit Th1. These guys activate interferon gamma, pushing macrophages into attack mode. So you get caseating granulomas and TB architectural signal. You forget the Th2 stuff. That's a different mechanism here. So IL-4, hot T bone e-ache. So that promotes your IgE. So it's IgE and allergic responses is IL-4. So no. A is IL-5, right? Hot T bone e-ache. So that's eosinophil and IgA activation. 10 is anti-inflammatory. So it inhibits the macrophage activation. So if you did like IL-10, that would actually do like inhibition. TGF-beta is involved in wound healing and fibrosis. So it's not that. Cool beans, guys. Here's the next question. Dude from Guatemala. Skin test is positive with induration, reveals caseating granulomas. And so what is the cellular response? It's going to be IL-12. Again, same idea. Not going to rehash this. IL-12, lymphocytic survival, or excuse me, I said IL-12. IL-7 is lymphocytic survival. So that's the only different one that we saw. And then also it's giving us IL-2 as an option. That's T cell proliferation, hot T-bone steak. So T is IL-2. And so T stands for your T cell proliferation. So it's not going to be in the Th1 interferon gamma axis. Because again, IL-12, Th1, interferon gamma activating the macrophages, boom, TB. That's how it works. All right, now let's talk about what happens after a stroke. Next high yield topic. All these are super high yield. Most important things that I know that you need to know after finishing this exam. After a stroke, the brain doesn't heal with scars made of collagen. It actually walls off the injury and a shield of what? The shield of astrocytes. Okay, so 66-year-old man has poorly controlled diabetes, hypertension, sudden loss of hemiparesis, and dysarthria, small infarct, and then histo shows cavitation and reactive cellular proliferation. Which cell type is most responsible? Astrocytes. Boom. So astrocytes are responders to CNS. After stroke, they have reactive gliosis. So here's your gliosis. This is where the glial cells in the brain and the spinal cord increase the number and size in response to injury. Cool. So we got some injury, cavitation. Which cell type is responsible? Astrocytes. Microglia are going to happen first, but then later on you get the astrocytes. So yes, microglia. You should think of these guys as early responders. These guys are like the phagocytes for the neural stuff. So these guys phagocytose the debris. Microglia. They're great. I love them, but they're not present long term. Oligodendrocytes, these guys make myelin. The CNS, they slowly regenerate. It's not going to be the scar formation. Neurons are going to be post-mitotic. What does that mean? So if they're post-mitotic, that means they don't regenerate. No regen powers. God did not give them regen powers. He just didn't want to. Schwann cells, that's not even in the CNS, guys. That's PNS. Schwann has a PNS is the way to remember that one. Hypertension, small, lacunar stroke, neurons die, red neurons 12 to 14, post-infarct, it's irreversible. Microglia arrive on day 3. Astrocytes arrive 1 to 2 weeks, and then 6 months later, you got the cavity lined with peripheral astrocytes and CSF. So in our practice question, we got this dude who's got some problems here. Lesions of cavitation and reactive cellular proliferation. So they're telling you got some damage. Astrocytes are going to be involved here, forming the dense glial scar. Cool beans. Okay, the next question. We have a 39-year-old man here, and he has recurrent abdominal pain and diarrhea for 8 months. Wow. He takes a proton pump inhibitor all the time. He's got some ulcers. Even in the jejunum, and lab studies show fasting serum gastrin levels are elevated. He shows a mass in the pancreas. Immunostaining is most likely to be positive for what? It's definitely going to be gastrin. All right, why? Because this is Zollinger-Ellison syndrome. The pancreatic mass is going to be making gastrin. So you get hyperacidity and refractory ulcers. So that's the answer. Glucagon, that's a glucagonoma. We had a problem on this. I think it was like part 4 of the series. VIP, that's going to be my favorite mnemonic. WADA, watery diarrhea, hypokalemia, VIP-oma. So it's not going to be that. Amylase is seen in pancreatitis, increased amylase. I don't know why I said that like I was like a 3rd grade bully on the playground. Yeah, not neuroendocrine tumors. And then here, somatostatin. You just think of like a somatostatinoma, like diabetes, achalaridria, gallstones. So yeah, this is just gastrins or Zollinger. So that's the biggest thing we need to know for this one. The high yield stuff is Zollinger is a gastrin secreting tumor. It's lurking in the pancreas and it hijacks acid secretion. So the gastrin levels are going to skyrocket and the parietal cells are going to go wild. So this is the parietal cell, go wild. All right, so now we have a 30-year-old woman who has got a history of estrogens, fatigue, and muscle cramps. And she has normal anion gap metabolic acidosis and pH of 6.2. They're asking like, what's the most likely mechanism? Okay, so basically the shortness of breath in a woman and her lungs are clear. So what gives, right? So her body is desperately trying to compensate by breathing fast because she's got that acidosis, right? So you're trying to get rid of that CO2. So she's breathing quickly. And so the problem is in her kidneys, right? They're not excreting acid like they should. That's called a renal tubular acidosis. You probably heard of that before. So specifically, there's going to be type 1. Okay, so type 1 with a serum bicarb of 15 and chloride at 110 and a pH of 7.25, we're looking at a type 1. So let's break this down, okay? Why is the answer not ketone production? Well, ketone, that makes us think of DKA, and that is an elevated anion gap metabolic acidosis. So that's not the answer. Cross it out. Ketone reabsorption is not relevant at all. Aldosterone deficiency. So here's where we have to know our types. So this is going to be type 4. And why? Because that's going to have hyperkalemia. That's what you need to know about 4. Hyperkalemia. And you can just think that the 4 is just a rearranged K. So the 4 causes that hyperkalemia. And so it's not going to be type 4, not that aldosterone deficiency. And then GI bicarb loss, that's from diarrhea. And there you'd have low urinary sodium chloride volume because of volume depletion. That's the volume depletion. All right, so that's that. Now, real quick, I've already drawn up, this is the lateral precentral central gyrus. So there's a 58-year-old man. He's got a brief tonic-clonic seizure and it goes straight to his smile. That's the interesting bit. And so it's not going to be left motor neuron facial, because that's just going to be like one side and the forehead involved. Same with the pontine. These guys are both going to present similarly. And the thalamic is only sensory, so it's not that. And the answer can't be E because that would be like hands, legs as well. Face, arm, leg, hemiparesis, so it's not E. And so the only answer left is going to be C, right cortical stroke. Okay, so that's that question really quickly. Just wanted to explain it. 3, 4, 5, 6, 7. All right, 3 more questions and we'll end this little part here. So let's go right here. We have a little spot. Okay, we got a 27-year-old woman, autoimmune thyroiditis, fatigue, muscle cramps. Look at all those labs. What's the cause? Failure to reclaim the bicarbonate. Now, this one takes a bit of explaining. So again, here we have a normal gap and you know that. You just have to calculate that out. So I'll just tell you, it's just going to be acid-base problem. And so in this patient, we have tachypnea and then we have a normal anion gap acidosis. Okay, and then what did we say from the last question that means, or 2 questions ago? Renal tubular acidosis. Okay, and so the buzzwords for this, you have to think of, here they are. Non-ion gap, hallmark RTA, chloremia, and that's due to your bicarbonate loss, compensatory chloride retention. If you're losing bicarbonate, you have to keep that chloride. The alkaline urine, dyspnea without a hypoxia, respiratory compensation. So kidney failure to secrete acid or reclaimed bicarbonate. So in an autoimmune problem, it's linked with renal tubular acidosis type 1 due to that secretory defect, amphotericin B, lithium, all this stuff, tubular injury. Obstructive uropathy of these cells, damage to the distal, hypokemia of 1 and 2. So let's understand why the incorrect answers are wrong. Lactic acidosis, we talked about this. This is going to be increased anion gap as well. These guys kind of go hand in hand. Psilocyte, that's definitely, anion gap elevation. You have a mixture of respiratory alkalosis first. Diarrhea, volume depletion. So the only one that is going to deal with like the acid-based problems and the renal tubular acidosis is going to be bicarb stuff. So that's how you answer that question. Boom. Now let's go just right next door. All right, so we have unstable mitosis. We got a stage 3-4 colon carcinoma. So it's an advanced disease, resistance to chemotherapy. We got some errors, so it's going to be chromosomal instability. So most colon cancers, especially the ones that spread, don't go fast. They actually take their time. So if you have stage 3 or even stage 4 diseases, the cancer cells mutate every single time they divide. And why is that? Why does that happen? It's thanks to errors during the G2, and those are phases of the cell cycle. So genomic instability means the chemotherapy that worked last month could actually be useless now. And the culprit is not the checkpoint failure or like a cell cycle arrest, it's the chromosomal instability. And so that's why the answer for this question is going to be C. Now, familial adenosis, that's the APCs. These drive the chromosomal instability. So colon cancer stuff, you think of Lynch syndrome. It's a microsatellite instability more common in right-sided colon cancers. P53, failure of the checkpoints. And CRAS, resistance to EGRF downstream. So the path is you have a mutation in the CRAS, so loss of tumor suppressor, like APC. So you go with the proto-oncogene like a CRAS or loss of an APC, and then it progresses, and then errors accumulate, and then it'll survive. And so now our trap answers are going to be cyclin, G1S, preventing proliferation, not causing resistance, P21 and P27, inhibiting cyclin CDKs, and decreased telomerase, senescence, and apoptosis. So different mechanisms. All right, done with cancer here. Let's get another one. 24-year-old has an investigational monoclonal antibody against LFA1 for Crohn's disease. Now he's got a non-healing skin ulcer with pus. What immune process is impaired? It's going to be adhesion. All right, so LFA. I'm going to zoom in here. Beta-2 integrin. All right, so your LFA binds ICAM1 defect. And so you get recurrent infections if you have LAD, right? Because LFA, especially the CD11 and the 8, or the 18, CD18, CD11A, these guys bind to ICAM1 on endothelial cells. All right, so they bind here on endothelial cells. Now, if you take natalizumab or like some blocker like in multiple sclerosis or something like that, basically you have integrin targeting drugs, you risk blocking immune cell trafficking, which is great for autoimmunity and it's bad for infection control. And what we need to know about this process, I'll go over here to like an endothelial cell, is that there are 5 steps. First, you have what's called margination. So the blood flow is going to slow near the vessel walls. That's margination. Then you have adhesion. Okay, so this is what we were talking about with our adhesion is when we have the LFAs and they bind to the ICAM and they adhere. Then we have transmigration. Okay, so transmigration, that's with your PCAM. I remember that by saying, please can I come inside? CD31. And that guides the cells between these junctions. And then chemotaxis. So chemotaxis, the neutrophils follow the chemical trails. And you should think of that like as IL-8, LTB4. I have a really short video on that on my channel as well. So LFA1 is the key glue in step 3. That's what we're talking about here. Leukocyte adhesion deficiency type 1. So beta-2 integrin problems, LFA, binding to ICAM, you have like antagonist. That's what we're dealing with in this question. So your integrins are definitely involved in this 3 stage. No pus, you get a poor response to infection, higher bacterial infections, and mimic SLAD. So this is when these guys are going to get close to the infection, but they can never actually step in. That's what happens if you block LFA1. It's a key integrin that's needed for neutrophils to adhere to the blood vessel walls. Without it, they just keep on. What do they do? What's the stage before? Roll in. I'm pretty sure that's from a funny YouTube video. Never sticking, never fighting, right? So LFA1 inhibitors increase the risk for infections. If you inhibit that, then you're going to not be able to do adhesion. You have to demarginate and roll for the rest of your life. So that's it. There's that question. Guys, look at all these topics that we've covered. This is crazy. It's crazy. All right, moving on. Let's go right here, shall we? 28-year-old woman, treatment, experimental integrin antagonist, itis. I got painful non-healing leg ulcers, positive for staph A, neutrophils are abundant, which protein interaction is impaired by medication. We went over this one. Stops the adhesion, not selectins. Why? This is rolling. PCAM, cis, IL-8, chemotactic, after adhesion, transmigration, and then CD14. That's just like your recruitment stage. Okay, so there's your practice question. Next, didn't think you could get away that easy. Flow shows absent expression of CD18. So what process is impaired? Tight adhesion to endothelium. Again, rolling, selectins, tight adhesion. That's our answer. Delayed. This is leukocyte adhesion deficiency. So it's adhesion. Transmigration. That's PCAM, chemotaxis, C5a, IL-8, recognition, and 8 sensing. Now I promise we'll move on. So here we have a hydrocele, 6-month-old boy. It's got painless right swelling in the scrotum. It transliminates, enlarges during straining. Which complication is most likely to occur? It's going to be an indirect inguinal hernia. Now, what we need to know is that when the testes descend, they bring a little piece of the peritoneum with them. That is called the processus vaginalis. So normally that tube just seals up, right? Normally just sealed up. But if it doesn't, you have a leaky channel from the abdomen, right? So this is the abdomen into the scrotum. So that fluid is coming in and hello, hydrocele, right? If it's wide, the abdominal contents are going to follow into, and you have an indirect inguinal hernia. All right, so buzzwords: scrotal swelling, ultrasound shows fluid around the testes, patent processus vaginalis. So small opening, communicating, large opening, indirect. They both occur lateral to the inferior epigastric. Lateral, indirect. MDs lie, medial, direct. Lateral, common in infants and young boys. Or you could say infants and young boys like to tell a fib. Lie. Testes canal. There we have it, folks. Next question. 62-year-old man, history of a 3-week cough, weight loss, fatigue, 40-pack. History, which condition underlines his findings? Inappropriate anti-hormone. All right, so check those are lungs that I just kind of drew there. So check these guys. Why? Because if they're a long-time smoker and they have a high mass, that's because of the small cell lung cancer. Why? Small cell lung cancer loves to secrete ADH. Right? What does ADH do? That hormone hoards water, dilutes sodium, and it concentrates the urine. And so that combo is going to have low sodium that we talked about, low serum osmolality, high urine osmolality, high urine sodium. And that's classic for SIADH, and that's our answer to the question. That's all there is to it. We can look at a trap answers like cerebral salt wasting. You'd have hypovolemia, low blood pressure, but we don't have that here. Diuretics causing hyponatremia, but often with hypokalemia, and they'd say that they used it. Primary polydipsia, dilute urine, not concentrated, because ADH acts on the distal convoluted tubules, so that would make sense that it would be concentrated here, but there would be dilute if you're drinking tons. Addison's, hyponatremia, hyperkalemia, and hypotension. All right, nicely done on this question, guys. You guys are killing it, by the way. Go put on some Ray music, listen to Harry Potter playlists on YouTube. I used to have that until YouTube copyright strike me because they're crazy. Anyways, 52-year-old woman has progressive proximal weakness, violaceous rash on her eyelids, constipation, 10-weight loss, perivascular atrophy, mononuclear infiltrates. What's the next step? Okay, so we have heliotrope rash. We have the Gottron papules. That's the scaly red plaques on the joints. That's the eyelid discoloration. I don't know why I drew it like that. And then we have joints here. So that's the Gottron papule. And proximal muscle weakness, so difficulty climbing, lifting objects. And we have increased aldolase. So we should look for an underlying malignancy here. So what's going on? We have dermatomyositis. Okay, so let's explain this. Well, it's a big word. So we got the skin, we got the muscle, we got the cancer. It's an autoimmune paraneoplastic red flag. All right, so our pathophys is we have immune-mediated inflammation, and that is going to target the derm and the myo, skin and the muscle. And that is going to involve the paramecium. So that's that connective tissue that surrounds the individual muscle, fascicles in a skeletal muscle. This stuff right here, paramecium. So that's affected. So you have muscle problems because it's attacking the muscle because it's derma-myo. Okay, so inflammation, muscle problems. You have a paraneoplastic trigger in adults. So autoantigens are up. So you're killing yourself. Why are you killing yourself? Because you have an underlying problem of adenocarcinoma. Boy, I love thunder. It is thundering outside. And so if you're not just treating the rash, you're also treating cancer. And that's why the answer to this question is going to be a CT scan of the abdomen and the pelvis. Okay, Hep C linked to cryoglobulinemia. That's where you have abnormal blood proteins. There are cryoglobulins, and they bind together at cold temperatures to restrict the blood flow and cause the damage to the organs like the kidney and the skin. So Hep C is like that clumping, different thing. Colonoscopy, not first line, unless you have symptoms that say you should go there. Diabetes, no. Endoscopy, the best starting point is going to be a CT scan. Okay, last question, guys. And then we finish the entire topics that I think you should know for the first part of NBME 26. Of course, this is like a 5-hour test, but my plan is to fill all of this up. If you're into that, like and subscribe. I can't tell you how much it would help making future videos if you just hit that like and subscribe button. Truly would help out a ton. I have 800 videos that are queued up and ready to go. Let me know in the comments of those shorts what you want to see, what you don't, and I'm going to make it better for you. Also, we're releasing an online platform. If you guys subscribe right now, the next month we're going to release some people, or as soon as the website launches, we're going to release a giveaway so you guys can have access. It's essentially like eWorld. All you have to do is like and subscribe. Okay, cool beans. Last question, and then we're 1/4 the way through for all of the topics you need to know for NBME 26, according to me at least. So 42, woman, fatigue, anorexia, salt cravings, skin darkened, hypotensive, unresponsive during a dental procedure, bilateral adrenal gland atrophy. What is most likely? All right, well, this is going to scream Addison's. So what's happening here is we have hyperpigmentation and sudden collapse. That leads us to think that there's a primary adrenal insufficiency. And so she's got some weight loss, abdominal problems, some fatigue, cardiac collapse. So that could be an acute adrenal crisis. Hyperpigmentation, that's the giveaway for me for Addison's. So anytime I think of Addison's, I think of excess ACTH. You're pumping that out like crazy, and that is going to cause hyperpigmentation of your mucosa. You have excess MSH there, okay? So that's the reason we have increased ACTH that causes the hyperpigmentation. Also, autoimmune adrenalitis, that's the most common cause of adrenal insufficiency. All right, so what are the associations? Autoimmune adrenalitis, like we said, A decreased cortisol, decreased aldosterone. And so you have tons of ACTH from the pituitary, stimulating the melanocytes and causing hyperpigmentation. They try but we still cannot get that aldosterone going. Low cortisol, high ACTH could be a part of autoimmune polyendocrine 1 or 2. The pathophys, autoimmune destruction, bilateral adrenal atrophy. So you're killing your own adrenal glands, loss of corticosteroids, so loss of cortisol, loss of aldosterone. ACTH increases due to low cortisol. So boom, this is gone. Why is it gone? Because of autoimmune problems. So autoimmune problem, cortisol is gone, compensatory, ACTH, due to low cortisol, co-released with MSH, causing skin darkening, stress. Correct answer, elevated renin. So the biggest things that I want you to think about this is somebody's like collapsing out of nowhere. They have darkened mucosa on autopsy. Well, it's the adrenal glands that are already failing. This is Addison, so the body's demand for cortisol rises, right? So it's low cortisol. Give me cortisol, guys. Okay, well, you want cortisol? Let me make ACTH. Well, ACTH co-secreted with MSH, and that's going to cause the mucosal darkening. All right, so that is the mechanism. And then so you might ask, okay, well, why renin? So in primary adrenal insufficiency, there's destruction of the adrenal cortex, right? And so you have low aldosterone, low cortisol, and low androgens. So what does aldosterone normally do? Well, you excrete potassium and hydronium ions, and you maintain the volume and the blood pressure. So if aldosterone is low, which is what's happening here, you have all that stuff going wrong. And so the RAS tries to compensate. So in your kidney, you have juxtaglomerular cells. They're sensing, hey, we don't have much aldosterone going on. And so what should we do? How do we get more aldosterone? Well, it's the renin-angiotensin-aldosterone syndrome. So we start with renin, we increase that. And so renin is always going to be increased in things like Addison's. Okay. So that's compensatory for aldosterone deficiency. And the aldosterone deficiency is happening because we have no aldosterone secretion because our zona glomerulosa is damaged, right? Remember GFR, zona glomerulosa, secretes the aldosterone, cortisol is in the fasciculata, GFR, R is the reticular, so the androgens, right? So those are just decreased because the destruction of the adrenal cortex, right? So all those things are damaged. Low cortisol can't make aldosterone, so the RAS is screaming, the ACTH is screaming. This is Addison's. ACTH screaming causes the increase of pigmentation. That's the best way I know how to explain this. Cool beans, y'all. We just finished the entire first quarter of this exam. So my idea is that you guys finish this playlist. You can watch all of my videos that I'm going to do on NBME 26, later 27, 28. And that's going to be like on my channel, you already have over 1,000 practice questions. They're all super high yield. So it's like a way that you guys can just passively sit there and study and hang out and have a good time. Remember to have fun. Remember, don't take it too seriously. Remember, we're all going to die someday. We live here on this little blue dot called Earth. So try to be nice to people. Try to do what you can. Try to like and subscribe if you're trying to make my day better. If you want to get the LED lights bouncing in the back end. And good luck with the NBME 26. We'll see you guys in the next video of this series. Thanks so much for your time. Peace out.